Good afternoon, everybody. I'm Dr. Saleh AlMesfer. Today we'll go through two subjects, Leukocoria and Congenital Cataract. These two subjects, each one of them need at least 2 hours for more detailed presentation. For this season, we may go through the subject, just an overview. If you need further details, it's preferable to go to any updated review or to see the details, and we need to know more syndrome details. Leukocoria is a vague diagnosis. Sometimes patients may present to the ER, to your clinic, and it means white pupil. White pupil could be various types of pathology. Could be just cataract, could be intraocular mass, could be pupil membrane or something like that. Once patient presented to you, most of these cases when they present, they have pediatric age. For this reason, we are looking at the pediatric age who are presenting with white pupil. It's preferable to take a good and appropriate details from the family, prenatal and postnatal history, trauma history. Sometimes parents may say that the child sustained a trauma, but maybe it's not relevant to that ocular pathology. For this reason, taking the history is very important, but don't rely on the family all the time. Sometimes you have to have a good clinical sense and way of thinking, because the family sometimes they think that this is due to trauma, but in reality it's not a trauma case. We need sometimes to examine the parents. Maybe the parents, they have history of affiliation for neuroblastoma, they have history of congenital cataract, they have history of familial dysplasia or something like that. Examination, you have to have good proper examination. And what I mean by proper examination, you have to look at the child, vision, slit lamp examination, fundus examination. If you face difficulties, you need to do a B-scan to look at the posterior ball if the patient cooperation is very limited. As rarely you need to put the patient for the examination and anesthesia, but if you find yourself facing difficulties to examine the child as outpatient, or the child is strong and is maybe 3 or 4 years, difficult for you to examine him, it's preferable to put him for the GA. Vision, intraocular pressure, alignment, as the patient has any form of strabismus, slit examination, fundus examination. B-scan is very important tool for you to look at the posterior ball if you face difficulties to examine the child, or you need to make the diagnosis. Sometimes B-scan will give you the clue and the diagnosis straightforward. Color Doppler imaging is available at KKISH if you need to know about the posterior ball vascularities. MRI sometimes indicated, and no fine needle aspiration indicated to make the diagnosis. Sometimes the intraocular process is a malignant process. If you decided to take a fine needle thinking that it's a form of endophthalmitis, or you need to do vitreous or their chamber tap or intravitreal antibiotic, sometimes there's a malignant process, and we have encountered some cases where patients subjected to fine needle aspiration from the vitreous or their chamber and intravitreal injection, or antifungal treatment injected for cases with malignant process. For this, you have to be very careful and to obtain appropriate consultation. CT scan is not indicated all the time, but if you find yourself that you need to do CT scan, it's okay. The diagnosis for leukocoria, you have to think about 3 things. Retinoblastoma should be in your mind all the time. All patients presented at young age, less than 5 or 10 years, you should think about retinoblastoma. There are cases where they present late. The oldest patient presented to us with retinoblastoma at 20 years old. He's a university student, and he presented with painful blind eye, glaucoma, and ended to be retinoblastoma. Congenital cataract is easy to be examined and easy to be diagnosed because there will be no intraocular mass. But there is a group of pathology, they call it pseudo-retinoblastoma, which is due to some abnormality within the ciliary body, vitreous, and retina. Could be persistent or hyperplastic from ocular vasculature, like what we call sometimes BHPD or BFD. Retinal abnormalities, toxic retinopathies, retinal dysplasia, inflammatory condition, toxocara, or any endogenous endophthalmitis in young patient with history of either poor immunity or exposure to any IV line in the ICU sometimes. History of trauma and neoplastic and proliferative lesions. يعلق جهازك مش كليك وات هذه بس كذا. The study, there was a study conducted long time to see what's the main causes of leukocoria. There was about 90% of cases of leukocoria due to persistent hyperplastic valvulosis, or what we call PFV. Retinopathy 13%, cataract 13%, coloboma 13%, uveitis, and sometimes larval granulomatosis. Congenital retinal folds, Coats disease 4 or 5%, vitreous hemorrhage, retinal dysplasia, and etc. We have to look at the leukocoria in two ways, either as a unilateral or bilateral. For unilateral cases, most of the time they are due to trauma, vitreous hemorrhage, HPV, Coats disease, medullary epithelioma, or retinal. Retinopathy usually is bilateral. Could be the severity is asymmetric from one side to another side. Down syndrome, sometimes they present with some congenital cataract or retinal changes or retinal detachment, PHL angiotosis, Norrie disease, and congenital pigmenty or extended retinostasis. All these causes, they may cause leukocoria due to retinal detachment and retinal changes in retinal dysplasia. Population. Retinopathy for immaturity also not. So the same slide. How could we differentiate between the most common confusing sometimes the BFB and the retinoblastoma. Usually retinoblastoma sometimes there's a positive or negative family history. 90% it says it's unilateral, and retinoblastoma sometimes 40% is bilateral. PHPV they have microcornea, microphthalmia. Rarely a cataract seen in retinoblastoma. Microphakia is seen in HPV, while it's normal in the retinoblastoma. Elongated ciliary process, you could see that if it is severe and the lens is absorbed and calcified, sometimes you see that processes of the ciliary body, while this is not seen in the retinoblastoma. Usually it is early in the young age, sometimes by family they will report that the eye is small since the birth time, while retinoblastoma sometimes may not be the case. Calcification is rare in cases of PFB, while it is common, or 86% on that. By B scan it's 86, by CT scan it's 95% in retinoblastoma. These are two slides. I mean, if you look at the slide, which one is this is a child with bilateral opacity, and this is a retinal masses. So this is bilateral retinoblastoma. This is a congenital cataract due to osmotic hyperplasia, punctatus syndrome. This is a slide. You can see the patient presented. You can see the retrolental mass. It's very clear. This is a child ended with some cataractal lens changes and peripheral synechiae. This doesn't have a normal, except if the patient develop what we call it cellulitis-like picture. Sometimes the tumor is growing fast, and then the skin process, sometimes patients ended with cellulitis-like picture, which could be considered as a cellulitis, and will sometimes be subject to IV antibiotic treatment, while it's in reality it is an intraocular process, ischemia process. This is the same child. You see that he has some cataract, which is very rare. You can see the synechiae. This after history of cellulitis-like picture. This is the B scan, which shows the mass and calcification. This is cellulitis-like picture patient. I mean, this patient may present to you and that and as a resident or a fellow who had no experience with retinoblastoma or intraocular malignancy, you may not think about malignant process, and you will start maybe the child's cooperation is very difficult. you can't examine the child, they didn't have a B scan in the ER, and maybe you're not at case patient at another hospital, and you will admit the patient and start an IV antibiotic. Well, the appropriate management, you have to examine the other eye because maybe the other eye has a mass. There's a 40% that is bilateral. Second, you need to look at the eye, the affected side. You have to go to speculum and look at the intersegment, still wall if possible. And before we start the antibiotic, because the treatment in cases like the cellulitis and infection, it's just to give an IV steroid or oral steroid, which will subside the cellulitis. We encounter some cases who are treated as endophthalmitis, indigenous endophthalmitis, and they were anterior chamber tab, vitreous tab, and intravitreal antibiotic, and the cytology report to the physician that there is malignant cells, not bacterial cells. This is a child with later presentation. You can see that there is some anterior chamber seeds and preauricular lymph node, and this is the cross after the nucleation. This is the CT scan. Histopathology, if you need more details about histopathology, it's preferable to look at one of the pathology book, discuss it with Dr. AlMesfer. You can see that the diagnostic fixes Windows thinner or just hemorrhoid results or pseudo result around the blood vessel. This is a written blastoma cell floating in the blood. This is what we see in late cases with bits and this optic nerve invasion with written blastoma. This is a child presented to us with bilateral physical eyes, ended with bilateral enucleation, and ended with this is the optic nerve invasion. We subjected her to adjuvant chemotherapy at King Faisal Specialist Hospital. She received 18 cycles at that time. This is the protocol 20 years ago, and now the protocol is totally different. We have just limited adjuvant to 6 cycles or maybe 9 cycles. She's still alive. She has 4 kids, 2 afflicted, 2 not. And she is already a teacher in one of the Workup schools in Riyadh. This is international classification, which could be looked at it by any reference. This is a classification. This is what I would like to share with you. In case with small tumor less than 3 millimeter, we call it group E, B, C, D, E, and this is usually unsalvageable and radiation. The success rate in group D sometimes with 12 with history with treatment of chemotherapy and so on. But in group C, the success rate sometimes is 60% that we could retain the group. These are cases of what we call it HPV or PFA, and you can see the ciliary process. And this is the D scan. You see the globe is small, and there's a stock between the optic disc and the peripheral anterior segment. But sometimes this pole is not attached to the posterior part of the lens, sometimes to the ciliary process. For this reason, sometimes there's a retinal fold, retinal detachment, and it's not a typical HPV, what you see in the drawing. This is a child presented with leukocoria in his left eye. This is the CT scan. We used to do CT scan. This is the, you can see the telangiectatic, and you see the color under the retina, which is more yellowish than creamy white. This is the cytology. It's a crystal of crystal from subretinal fluid. You could see some cases like in congenital pigmentia, but usually these patients will not be seen in eye hospital. They will be seen in general hospital where there is more geneticists and pediatrician. We'll see these cases, skin finding and the retinal finding. For this reason, if anyone who working in a general hospital, he may see this cases. But in this hospital, rarely we saw cases like that, because sometimes these patients are not seen in this big hospital, in the eye hospital. Murray disease also it could see could blindness, cataract, ossification, bilateral, the bathroom is X-linked excessive. It could be see patient with just a small scar in the retina, which is we didn't know what's the cause. Sometimes this is a larva, this is sometimes toxocara or trauma. Or the season I was called by sometimes by the ER resident to look at a patient with retinal blastoma. And when I go there, it's just a retinal coloboma. And sometimes they would just like to be sure. It's not, I'm not blaming them, but it's maybe preferable to use an indirect and look at it properly and do be scanned. There's no masses, it's clear, it's a coloretinal scar, no need to worry about the patient. It's a case of medullary epithelioma. The last case of medullary epithelioma we saw just last week was referred by Dr. Shadar Furahi from the National Car. The child was 9 years old with left eye blindness, no light perception, retinal detachment, and ciliary body mass. We offered the family a recreation, but they'd like to have international opinion. We provide them with an email of Dr. Carol Sheet, and we provide them with all the details. We expect them to come back for us the next week for possible education. But diagnosis for us, primary diagnosis with epithelioma, since the eye has no light perception with the RG and VEB, MRI, or compatible with no prognosis for the vision. For this reason, this eye should be removed as soon as possible. It's a case just so history of congenital morning glory syndrome. Okay, well, this is just a scan. I've been asking the hospital for many years to provide the AR with scan. Most of you will go and rotate in the DID and try the scan for a while, but this rotation sometimes it's only 2 weeks, and 2 weeks in optometry. I don't know what's the process of rotation now in the DID, but I prefer to have a DID scan in the ER. The scan in the ER, it will help you a lot. It will help you first to know how to handle the scan. It will help you to make the diagnosis. Sometimes it will save your time from dilating the patient and keep the patient waiting for 1 hour while there's no intraocular abnormality that needs to be seen by the dilation. This is a case of me. Look at the scan. This is normal scan. There is no masses. I mean, this is just a vitreous hemorrhage. This is retinal blastoma, and this is a PHP. Let's see, what is this one? Yalla Amar. Is it retinal detachment or posterior vitreous detachment? This is the A scan. Okay, retinal detachment with the A scan is 100% for this season itself. This is a vitreous hemorrhage with the vitreous detachment. This is a retinal, I mean, BHPV. You could see that this is retinopathy prematurity. I mean, funnel shaped RB. We used to do color Doppler imaging for our patients, just for our research project and to see the vascularities. Sometimes we find good perfusion, sometimes there's no perfusion, and which is compatible with the histopathology finding, which is, we conclude that you can see that some patient has no perfusion. And when you look at the optic nerve, it's included. I mean, the central retinal artery is included in the optic nerve, which is compatible with no circulation and no perfusion with the lesion. This is just color Doppler. My message for leukocoria patients, I mean, first you have to think that all children with abnormality or vague abnormal masquerading presentation with vague history, think about retinal blastoma. I'm trying to keep this message for all of the residents and fellows that the reason behind that we still encounter, I mean, cases were managed by consultants wrongly. Sometimes patient is presented to a vitreoretinal surgeon. He will think that this is a case of endophthalmitis, case of fungal. We encounter cases where they are given antifungal. We encounter cases where operated by a vitreoretinal surgeon at KKH and at King Abdulaziz University. They are retinal blastoma cases. The case I mentioned about the medullary epithelioma was seen by a vitreoretinal surgeon before he was referred to us. And the family, they didn't mention to the physician anything. He told them that he has just chronic retinal detachment, not overlook. While there is a ciliary body mass, which you see, don't look at the patient. Or he's one of the good retinal surgeons. For this reason, sometimes when you are overwhelmed with the patient in the clinic, sometimes you may miss something. For this reason, it's very preferable to think about retinal blastoma all the time. All patients will present with vague, abnormal, masquerading presentation. You have to think about retinal blastoma. We saw cases diagnosed as codes, taken to the OR for vitrectomy and for laser and for intravitreal injection, and we examined the patient, we stopped the process, and it's a retinal blastoma. This is happening at KKISH, and every month we have to see some patient with our colleague in the retina to be sure that it's not a retinal blastoma. Since this is the case, they start to be scared, and this is not the way that we are aiming, but we need them to think about abnormal presentation. Sometimes patients may present with some exudate or it's even retinal blastoma. One of the most important points is please don't operate in any patient without B-scan. B-scan is very important. The reason behind that, I encountered the patient were presented with a traumatic cataract and seen by one of our colleagues in pediatric field, pediatric ophthalmology field. You didn't need to have cases. I mean, if the police told you not to cross the traffic light, I didn't need to have accident in that traffic light to stop doing that. If somebody told you, okay, stop. For this reason, please don't operate in any patient without B-scan. Even patient with for phaco and straightforward vision 20/20 before, now his vision is hand motion of 20/100. B-scan is very essential to keep you safe. Sometimes you may end it with cataract surgery where the patient already has retinal detachment or peripheral retinal detachment, which was not detected. The second subject I will go through it is congenital cataract. Congenital cataract is very fruitful for the pediatrician because once we do a cataract surgery, correct the patient with optical methods, either glasses or lenses or contact lenses or ICL, these kids will grow up, if they have normal IQ, normal chromosomes, they will grow up, they will see, they will drive, they will present to you after 20 years with 20/20 vision, with normal IUB, without complications. That's why you need to do. It's not preferable to end it, to keep the patient to push for blindness after cataract surgery, which is, we encountered some cases ended with the blindness while they have straightforward cataract that could be prevented from such complication. We'll go through the congenital cataract. This is the same child that we saw before with osmotic. Congenital cataract could be isolated or associated with systemic conditions. Could be congenital, could be acquired, could be inherited, sporadic, unilateral, bilateral, partial, complete, stable, or progressive. 10% of all vision loss in children worldwide is due to congenital cataract. Could be bilateral cataract, which is 50% due to a mutation of gene that code for lens clarity. But the patient is normal IQ, normal development, everything is normal, but he has some wrong coding for the lens protein clarity. Idiopathic could be seen at 30%, familial could be seen at 60%. The decision of the child presented to you, sometimes you will find that there's bilateral, and mother is maybe also blind or father blind. I have a family, the father is blind due to congenital cataract, and the mother is blind due to congenital glaucoma. And all the kids ended with ocular abnormalities, either congenital glaucoma or congenital cataract, which is very sad for them. For this reason, it's maybe preferable not to encourage family to, blind people with congenital cataract glaucoma to get married to somebody with similar condition or ocular abnormalities. Chromosomal abnormality could be seen with Down syndrome, with chromosome 13 or translocation, deletion, or duplication of chromosome. Craniofacial syndrome was Hillerman-Streiff syndrome. See, this is the Hillerman. This is a very young baby. This is an old patient. We encountered one patient operated at Cakish at 9 months old for congenital cataract. When these patients presented to you, you think like they have cataracts. Usually they have resolved membranous cataract, and it is a straightforward surgery. There's no problem with the surgery. The problem with putting the child to the GA. There was a 9-month-old child with this syndrome put to GA at Cakish, room 1, and passed away on the table. For this reason, you have to think about the congenital cataract. You have to think about the patient's life. Is this patient's prognosis, life prognosis is good? Could he tolerate the GA? For this reason, I mean, it will not be nice for you to push patients for surgery when the prognosis for life is not good. If you think the prognosis, life prognosis is not good, don't avoid it. Let somebody else to do it, but try not to do surgery. This is a case of familial chondrodysplasia punctata, autosomal recessive. Usually these kids, due to they have psychomotor retardation, cataract, and early death, usually they have elevated plasma photonic acid. Most of these kids, they will die before 5 years of age. With improvement in the medication and treatment, sometimes they survive until 10, but finally the child is bedridden, not talking, family just taking care about somebody who's handicapped at home with bilateral aphakia if you decide to do the surgery, but finally he will see favorable. The life prognosis for the child is not good, try to avoid the surgery. Even if the family pushing for surgery, they do it. We encountered cases where operated here, and then the follow-up, no more follow-up, the child already passed away. The family, they have another child with the same problem. They bring the patient. I refuse to do the surgery. And they try to find somebody to do the surgery. Finally, they did it in Jeddah. But I didn't know what's happened to that child. He's still alive. Could be due to musculoskeletal disorder like Congenital Anomaly syndrome. You can see the child with aphakia and glasses on the side. Renal syndrome like Chloe syndrome and Albert syndrome. For this reason, sometimes you may be the first one who will protect the patient from progressive renal changes and renal failure if you diagnose the genetic patient with Chloe syndrome or Albert syndrome. Chloe usually is exclusively in males. Could be metabolic, like galactosemia, which is, very good type of syndromes that could be, the mentality could be improved if the early detection is done and the child has restricted that galactose. This IQ would be normal, he could grow normal. If you didn't discover and was happened when the patient was discovered 2 years after the surgery, which is a sad child IQ drop, and it will be very difficult to improve his IQ after that age. Could be Fabry disease, and you can see the some changes. Wilson disease, and you can see some precipitated in the lens capsule. Intrauterine infection, toxoplasma cytomegalovirus varicella, heterogenic to corticosteroidal topical treatment or systemic radiation exposure, which we have encountered sometimes after radiotherapy in retinoblastoma ended with radiation-induced cataract. Could be unilateral idiopathic in 80%. Ocular abnormalities, and sometimes due to hyperthermia or PFV. Retinal detachment sometimes due to retinoblastoma or due to trauma. What is the workup? Once we have a patient, we sometimes with the patient to the clinic. We'll look at him, do B scan, normal cataract, and we'll book the patient for surgery. You might not encounter somebody who's going to work up the patient. It's preferable to work up the patient because you may make the diagnosis. Cataract is doable, but systemic disease, if you missed it, it will not be nice. For this reason, it's preferable to work up the patient to do galactose metabolism urine for reducing substances, galactose 1-phosphate uridyl transferase, and galactokinase test. You could ask for TORCH to rule out any history of intrauterine infection, metabolic disorder, urine amino acid test to rule out Lowy syndrome, serum calcium low in hepatoparathyroidism, phosphorus will be high in hypoparathyroidism, glucose, and ferritin. This is just a simple workup, but meantime, you have to consult the genetist and ask him to look at the patient and the pediatrician to be sure that the patient is normal. Some cases it's straightforward, like Down syndrome. It is straightforward, just you need to clear up for the surgery. It is straightforward diagnosis. The child is as Down syndrome. You could proceed with the surgery. You didn't need to go with all this workup. But if the cases is not clear, it's preferable to do a proper workup. Morphology is sometimes could give you a guideline to make the diagnosis. Spoke lights could be seen as Fabry syndrome, where you could see corneal walls or myosidosis, you could see hepatosplenomegaly. And diabetes, you could see some vacuoles, and sometimes you find that the blood sugar is high in these kids. Multicolor reflex and hypoparathyroidism or myotonic dystrophy, where you could see low serum calcium level or characterized by facial feature anatomic grip. Green sunflower could be seen with Wilson disease, and thin disciform could be seen with Lowy syndrome. And these syndromes, I mean, each one of them need at least half an hour presentation to discuss all this presentation. For this reason, if you need more detail, it's preferable to be familiar with the name of the syndrome, know what's the defects of the syndrome. The defect is it genetics or the genetic reason or metabolic reason. Try to see some slide could make the diagnosis in the clinic. You didn't know anything about such a presentation, but for more detail, it's preferable to send these kids for a genetic clinic. This is some of the morphology. You could see the nuclear lenses. Not all cases sometimes need surgery, but we'll go through that after this slide. This is lamellar. Like this case, sometimes if you could do refraction, you could see the clarity of the visual axis. You don't need to push the patient for surgery. Could you see posterior intercorus, I mean, and even droplets like it could be seen in galactosy. Posterior capsular ossification, persistent pupillary membrane with cataract. Sometimes it's just a small sectorial. This will not affect the lens, and the lens is clear. You didn't need to go out and release this adhesion. Just forget it. Just provide the appropriate correction with glasses, because if this is opacity, sometimes there's an lenticular astigmatism, not a corneal, it's a lenticular astigmatism. For this reason, you have to have a proper reflection. Could be seen, like in this case, like a persistent fetal vasculature, or you could see the ciliary processes, or you see the strand between the optic disc and periphery. Sometimes it's adherent to the posterior capsule, sometimes it's adherent to the peripheral part of the retina. This is a blue dot cataract, which could be progressive, and this is just mitten dots, could be seen with persistent type of. It's the simplest form. I mean, the persistent fetal vasculature is very white. It's not present in one severity. Sometimes there's an attachment, very thick membrane, non-operable, and prognosis. Sometimes it is just a small posterior capsular ossification with small blood vessel like extending between the disc and the lens, and you could do cataract, you could do capsulotomy, you could do intervitrectomy and put IOL and macular looks okay and everything is fine. These cases will do very well. Sometimes it's very small opacity in the capsule, like this mitten dot spot, where you don't need to do any form of surgery. All patients with congenital cataract, you have to do a lab work, and as indicated, you have to do proper examination, vision, IOP, check for nystagmus, see if the child has strabismus. Because sometimes they have no nystagmus, no strabismus, they have congenital cataract. This means that maybe the surgical indication is very low. Is the fixation centric or eccentric? If the child has eccentric fixation, is this due to retinal abnormality or due to poor vision? I have to do a slit lamp examination and check the IOP and look at the iris. If the iris has normal crypt and it's not smooth and not velvet مخملي ما هو يعني في شغل أجزاء الإيرس فوق. These patients, they will do well after cataract and they will not develop glaucoma easily. If the iris is smooth or velvet, not dilating well, the chances for this patient to have secondary glaucoma due to a fake is very high. For this reason, you have to explain to the family that your child have a congenital cataract, but there are high chances for these kids to develop glaucoma in the future. Check the corneal diameter and do the scan, look at the axial length, do IOL calculation, and when you have to do the surgery for patients with congenital cataract. They called you Amar for a patient in something like Amar. An ICU, and the nurses, they noticed that white pupil in both eyes. And you requested B scan, game posterior bodies normal. You look at him with slit lamp, seem to be congenital cataract, and the child is 7 months premature in ICU. When you will operate?
Speak. Right after the heart, bilateral heart.
I encountered one child was in ICU. There was a visiting professor from one part of the country. In that hospital, he was called to see the child. He looked at the child, he said, there's a cataract both eyes, we need surgery. And then the anesthesiologist, the pediatrician, and they decided to find a way to put the child for GA. They put the child who is still premature, and they took him from an ICU, put him for surgery, cataract surgery, and he put IOL, child ended with blindness both eyes. For this reason, I mean, timing for surgery is very important. Doesn't mean the cataract is indicated to be operated at that time. I mean, this is a very sad, one of the saddest cases that I came across with congenital cataract. To take a child who's premature in ICU, put him under GA, do surgery both eyes, to put IOL. I can't find any justifying reason for that. If the patient in ICU didn't operate till he is clear from ICU, and after that you have to assess. There is a range where you could operate with this patient. First, to be sure that the child health is priority and he's going to recover from an ICU, has no syndrome, no metabolic diseases, and he's medically free after the ICU. And you have to be sure that this scan is done, no retinopathy prematurity, no retinal detachment, because if there is something, you need to consult the retina, because maybe you saw the child 2 months ago in ICU, this scan was normal, but after 2 months, there will be retinal detachment where nobody pay any attention to it. For this reason, you have to be very careful. Don't operate on the child in ICU till he's medically clear and free from any medical need. For patient normal kids, I mean, for unilateral, it's preferable to operate after 1 month. No need to put the child for surgery within the first 6 weeks or 4 weeks. We used to do surgery in the first week, in second week, in third week. But we discovered with time and literature and supporting that there is no indication to put these kids for surgery in the first month. For bilateral cases, you have time longer frame, up to 2 months, it's okay. As long as your surgery is perfect, good lens aspiration, good vitrectomy, okay, the child will catch you. Second important point is the phakic correction. Once you operate the child who is maybe unilateral or bilateral, if you use unilateral, it's more difficult because sometimes the family indication is not at expectation and you may need to put contact lenses and the family will face difficulty to find the contact lens. They use the contact lens and by 3-6 months you'll find that the family didn't use the contact lenses. In these cases, proceed and put secondary eye. Bilateral glasses will do excellent job. Don't worry about the glasses. They are not looking good. They are ugly. They are big. But in reality, they will maintain the good vision. In this case, they obtain 20/20 vision without difficulties. And you could put secondary eye at the age of 6 months, 1 year, 2 years, 6 years. There will be no harm. Which type of IOL you have to put? If the patient, secondary surgery, secondary insertion, usually you put it in the sulcus, usually it's 3 pieces. If it's in the primary surgery, you could put it in the back. Avoid iris fixed lenses, young children or artisan lenses because they are not stable and they may cause complication. No anterior chamber IOL at all. If the child has aphakia and you can't put IOL because either the capsule is violated or maybe the lens was subluxated and the zone was weak or traumatic, don't put in the anterior chamber. Make the child aphakic. Try with contact lenses. If you failed, try to go and do scleral fixed IOL if you have the skills, or ask somebody from anterior segment to help and put scleral fixed IOL. Multifocal versus monofocal, progressive, toric, all these type of lenses, you have to think about it before you put it. Normal lenses will work. Progressive now is working very well for adult patients after phacoemulsification. It may have could be good choice in pediatric age group. Unilateral cases, if they are 6 months and above, you could put IOL easy. Sometimes they put it even 3 months or 4 months, but they have to explain to the family and they have to obtain a good surgery. If the surgery is not good, don't put IOL. And you have good skilled surgeon and did good cataract, good vitrectomy, good capsule. You find that everything is straightforward. You could put IOL, put IOL. But don't try to squeeze the IOL by force because the eye size is not as adult patient. And sometimes the overall diameter of the lens at birth is only maybe 8 millimeters. Cannot accommodate IOL in the back. With time, will grow up and could accommodate. In these cases, sometimes you need to put IOL in the sulcus. For bilateral cases, you could put the lenses at 12 months for each. What is the precaution that need to be taken? If the anterior segment is normal, that means they have normal straightforward surgery like adults, but the lens is very soft in pediatric age group. It's preferable to obtain a successful capsulorhexis. And when you have to do anterior vitrectomy, should we do anterior vitrectomy for all age or pediatric age? No, up to 6 years, do it. The child is less than 6 years, do anterior vitrectomy. Because by 6 years, if he's 8 or 7 or the posterior capsule opacified, after you could take him to the eye laser and do capsulotomy as outpatient. Those patients with abnormal mentality, it's preferable to do posterior capsulotomy because maybe they're not able to sit and cooperate for the laser capsulotomy as outpatient. Medication that will be used after lens aspiration, usually steroid, antibiotic, or cycloplegic medication to keep the people dilated. For those patients with microphthalmia, congenital cataract, it's preferable to do peripheral iridotomy. Okay, this will prevent any chances for pupillary block. Sometimes you will do good surgery, good leukocostomy, good capsulotomy, good vitrectomy, but no peripheral iodectomy. And the child, next morning, you'll find him that he's crying, he's screaming all the night. Mother said he couldn't sleep, he's in pain. You look at him, difficult examination, but because if you have history of good surgery, you'll think it's a normal, but in reality, it's a glaucoma. The cornea is hazy, maybe the IOP is high. In these cases, take the child to the OR, do the good vitrectomy again, and peripheral iodectomy. If you ignore him, the child will come after a few weeks with ophthalmia, secondary glaucoma, and difficult to manage at that time. But if you do it within the next 24 to 48 hours, up to 72 hours, you could rescue them. What's the power? It's depending on your experience, but you have to know about the history of the family. If the family has history of myopia or hyperopia, age, K reading, corneal diameter, axial length, laterality, indication for aphakia correction. Age at cataract, if you look at the table, this table is not 100% accurate. You have to look at your experience, patient age, axial length, and based on that, you could think what's appropriate. If you find that the child axial length, he is maybe 6 months, but the axial length is more than normal for his age, you have to be careful by putting the high power necessary. One of the important things that for unilateral cataract, either due to trauma or developmental cataract, do refraction for the contralateral eye, and know the refraction. The refraction in the contralateral eye, let's say it is acceptable, -2 or +2, it's okay to put this child, emmetropic, or try to make his refraction after surgery similar to the contralateral eye. If the child in the contralateral eye is minus, let's say 6, and you need to put IOL in the traumatic side, you will be thinking, oh, what power I have to? Should I keep him +2? Should I make him -5 like the contralateral eye? There is a debate and all the surgeon. For me, I would try to give him similar outcome to the contralateral. The contralateral eye is +5. I would undercorrect him too much to keep him hypopic. If the contralateral is myopic, I'll do the IOL, increase the power to make him myopic similar to the other side. If the power is in the contralateral is in the range of -2 up to 3, or hyperopic -1 to 3, it's okay to make him hyperopic. Complication of congenital cataract is the posterior capsular opacification, which is common. This is a chart. You can see that after he had laser is done. Endophthalmitis is the disaster complication that you didn't need to see it after congenital. We encountered one case presented to Kekish a few months ago, was done outside, which is very sad. Patient ended bad outcome, physical, and nothing could be done. For this reason, it is one of the complications that you didn't want to see it either in your adult patient or young patient. But in young kids, it's more difficult. Sometimes the IOL is subluxated. One of the important points is before you do any intraocular surgery of the pediatric age or an adult, be sure about that. That child had bad severe blepharitis. Is there is nasolacrimal duct obstruction or not? Patient may present with congenital glaucoma or congenital cataract. Mother is worried about the size of the globe or worried about the white opacity in the lens, but she didn't think about the tearing as a problem. For this reason, be careful that these kids have no nasolacrimal duct obstruction. They have nasolacrimal duct obstruction, put the patient to GA, do probing. You need to give antibiotic after 2 weeks. Bring the child assist the child. If there's no more tearing, no more discharge, and he's medically clear from ophthalmic side, we could put the patient for cataract surgery or glaucoma surgery, or intraocular surgery. To intubulate in a child with history of tearing, conjunctivitis, cerebrophlitis, because you didn't want to end it with a difference. I think we are done. If you have any question.